everyone, and welcome to Partner Snippet. Today I will be talking about the various aspects of curriculum. My name is Heather Peters, and I'm a consultant with Partners in Medical Education. I call this the 360 view of curriculum because often I find that when I'm talking to people about their curriculum, they say to me, well, what do you mean curriculum? Is that the written curriculum? Is that the scholarly activity piece? Is that rotations? Where does competency-based goals and objectives come in? So I've organized this snippet to talk about all of the different pieces of curriculum because actually the word curriculum encompasses everything. We will start at the top, overall goals for the program, or now that we are in the self-study phase, we also call these the aims of the program. That's a new word that's come in since we started the self-study. So when we're talking about the overall goals for the program, we want to go back to our program requirements. And in this case, we want to go back to our common program requirements. Everything I talk about today is right there in your common program requirements. It is usually just a line or two, and sometimes people don't understand that just because there's a brief mention, how important it is to the overall foundation of your educational program. But if we go back to the common program requirements, we would start with 4A, and that says overall educational goals for the program, which the program must make available to residents and faculty. So there's a few things to keep in mind here. This is a fundamental element to building your curriculum, your entire educational program. If you don't have these overall educational goals, then you have nothing to base your program on. These goals should be reviewed by the PEC, Program Evaluation Committee, to ensure continued relevance. So you can't just write the goals once and then say, well, check, that's been done for 5 years. They should actually be reviewed on a regular basis. Particularly now that we are doing self-studies, we need to be making sure that our aims, our goals, are relevant and continue to be relevant. They are a major component of the self-study process. So even if you felt like overall educational goals weren't that important prior to this, I need to reiterate with you that they are a major component of the self-study process, and we are all in a phase of the self-study. Even if you're in the pre-phase of the self-study, you're still in the self-study process, and we all need to be learning about self-study. So the next piece we're going to talk about is didactics. Didactics is indeed part of the curriculum. So when we talk about didactics and we then go back to our common program requirements, we see a very brief phrase, regularly scheduled didactic sessions. This is not very prescriptive, and that's one of the things that we need to keep in mind, that it's not very explicit. And so each specialty has usually gone back into the program requirements and put in their own specifics, although rarely will you find that a certain amount of hours per week per se would be required. So this is something that it is very good to have networks within your own specialty so you can discuss what is an appropriate amount of time. The quality of your didactics is something that should be asked about on your program's annual evaluation. Your APE survey that you send out at the end of the academic year to your residents, fellows, and faculty should definitely be asking about the quality of the didactics and what they think would be good improvements for the following year, and just always getting a lot of feedback about didactics. You'll see why in the next slide. It should also be protected time. Often I see programs getting citations for lack of protected time, and then that leads into another citation. So let's look at the connection between didactics and the requirement for didactics and the resident survey. We know how important the resident survey has become. Those who have received citations recently often see resident survey data as one of the parameters for the citation. So what is it on the resident survey that might be linked back to didactics and the quality of didactics? Well, in the faculty section, we have these questions. Faculty are interested in and promote resident education. And then there's this one. promote an environment of inquiry. Here's some questions to ask about your program if you perhaps got some low scores in these particular areas. Do your faculty attend didactics? Do your faculty members provide lectures on a regular basis? Do your faculty participate actively in didactic discussions? If you can answer those questions in the affirmative, then you are in a pretty good place, and you should reaffirm these issues. The faculty do attend our didactics, the faculty members provide lectures on a regular basis, and that they actively participate prior to that resident survey, so that residents can keep that in mind when they're thinking about, is the faculty interested in and promoting resident education and promoting an environment of inquiry? Some best practices are that faculty attends and participates actively in resident didactics, and that the faculty reviews include data about attendance and participation. So when you do that annual review for each faculty member by the chair, or the chair and the program director, or the chief and the program director, that includes data about their attendance at didactics and their participation in didactics. Often I see just the attendance, but there needs to be some way to evaluate their participation also. And then faculty should be expected to provide lectures on a regular basis. If you are a core faculty member, you should be providing lectures on a regular basis, and those lectures need to be kept up to date and be evidence-based. So there's another part of the resident survey that has connection back to didactics, and that's the educational content section. And that's the appropriate balance for education, as well as the education not compromised by service. And you might ask, well, how is this related to didactics and the quality of didactics? But if your trainees are too busy with patient care to attend didactics, that will lead your RC to think there is not an appropriate balance for education, and also that your education is being compromised by service. So a best practice in this area is to make sure that the balance between didactics and patient care is carefully evaluated on an annual basis during the APE. This should be an important element of the data that is reviewed during your APE each year, so that you can make sure that your didactics are meeting the needs of your learners. The next piece that we're going to look at is the competency-based goals and objectives. A lot of times people think that the curriculum is just the written curriculum, but as you can see, there's a lot more to it than just the written curriculum. But this piece is often referred to as the written curriculum. If we go back to the requirements, it says competency-based goals and objectives for each assignment at each educational level, which the program must distribute to residents and faculty at least annually in either written or electronic form. Some elements to keep in mind here is that there must be different goals and objectives for each training level. If you have a resident go through the same NICU rotation 2 years in a row, there must be rotation goals that are specific to the PGY1 NICU rotation and then the PGY2 NICU rotation. If you have residents an OBGYN resident go through time on labor and delivery ward 4 years in a row, you must have different goals for each training level. Your goals should have action words at the beginning of each learning objective. If you do a search on the internet and you look for action words for writing goals, you will get a plethora of different lists. Stay away from the words learn or understand, because those really aren't considered action words. Those are passive. And then also, you must provide learners, faculty access to learning objectives, ideally at the beginning of the rotation, but sometimes that isn't always possible, or sometimes it isn't even always the best idea. For instance, continuity clinic. Although you might have different rotations of continuity clinic throughout the year, you might not want to revisit the continuity clinic goals every single time. So you have to make a decision as to whether this is the best way to do it. Most programs these days use their residency management system to send out the goals and objectives via an email before the rotation begins. So let's look at the resident survey connection for your written goals and objectives. In the area of educational content, they ask if they were provided goals and objectives for the assignments. There's a very direct connection there. The variety of patients also is something that is connected to your written goals and objectives. Questions you might want to ask yourself about your program is, how are goals and objectives provided to your trainees and faculty? And also, does your program evaluation committee track patient variety and acuity for your program? Because you may not be meeting those goals and objectives if you don't have the right balance and variety of patients. Often we have goals in our goals and objectives that aren't being met if the variety isn't consistent and it's based on who walks through the door. And so although we might not have that much control over the patient variety, we need to make sure that the patient variety that we do have is reflected in our goals and objectives, and do our best to create that variety of patients, because we are asking our residents on an annual basis if they think that the variety of patients is sufficient for their education. Best practice here is to send goals and objectives via your residency management system just prior to the start of a rotation. And also to set up tracking and trending for patient acuity and variety for the APE. You're going to notice a trend that a lot of these things should be asked about in your annual program evaluation. That is the time that you can get some understanding of how your residents and fellows are feeling about these areas, and then you will have some opportunity for dialogue before they fill out the resident survey the following spring. The next piece we're going to talk about are the rotations, and I'm putting CLE after that because we're starting to see this a lot more in the ACGME presentations and things of that nature. CLE stands for Clinical Learning Environment, and also that's part of CLEAR, which is Clinical Learning Environment Review. But if we look at the rotations as our CLE, or our Clinical Learning Environment, it gives us a new lens to look at a piece of the curriculum. Once again, we'll go back to the requirements. It says a delineation of resident responsibilities for patient care, progressive responsibility for patient management, and supervision of residents over the continuum of the program. It's a lot more in this one than the didactics. These things are the things that we need to remember. Patient responsibility for patient care. Your procedural competence is an element of responsibility for patient care. So anything that's related to procedural competence would be part of this. Progressive responsibility for patient management. Promotion criteria reflects the progression, and each program should have developed by now promotion criteria. How do we know when they're ready to go from year 1 to year 2, from year 2 to year 3? It isn't just a matter of time. There should actually be promotion criteria. And then also supervision over the continuum of the program. Well, that's your supervision policies. And supervision policies are an extremely important policy, which needs to be reviewed on a regular basis. None of our policies can just be written once and then checked off a list. All of our policies need to be reviewed on a regular basis. And this is one of the jobs of the Program Evaluation Committee. Connections to the resident survey. Sufficient supervision. Appropriate supervision. Questions to ask yourself about your program in this area. Is your program supervision policy up to date? Does it include the words direct observation, indirect observation, and those key terms that the ACGME emphasizes? Is your supervision policy well known by the trainees and faculty throughout your program? The best practices are to ensure that at least annually your supervision policy is reviewed by the community, and ensure that faculty can articulate the different types of supervision. The next piece is scholarly activity. And often this is not seen as part of the overall curriculum, but it is in that same section as the other curriculum pieces from our common program requirements. And it says The curriculum must advance residents' knowledge of the basic principles of research, including how research is conducted, evaluated, explained to patients, and applied to patient care. Residents should participate in scholarly activity, and sponsoring institution and programs should allocate adequate educational resources to facilitate resident involvement in scholarly activities. Often this isn't considered part of the curriculum because there is quite a bit written from the ACGME about scholarly activity. But when you're looking at the framework of your curriculum and your educational program, this is something that is part of the curriculum. And the resident survey connection is in the area of educational content. Are your residents going to report that they're satisfied with scholarly activity? Are they going to report that they have access to reference materials? I have seen citations recently for access to reference materials, and that is kind of surprising because everybody has a computer, and most of the libraries now in the hospitals are all online. But there have been some places where the access, even the online access, isn't ideal. So you will see this in a citation now and then. Questions to ask yourself about your program. Are the scholarly activities that are expected of your trainees supported by research infrastructure? And by research infrastructure, I mean, do they have access to reference materials? Do you have an IRB that they can work with and is cognizant of how resident research and fellow research might be different from other types of medical research? Do you have a research department? Those are things that are part of the resources that we need to have in our institutions. Is there active mentoring for your trainees' scholarly activities? The ACGME believes that residents and fellows should be mentored in their research endeavors. And so this is an important piece to remember. It's also important to remember that if you do have active scholarly activity, you get credit for resident fellow scholarly activity as well as core faculty scholarly activity. So it really benefits your program to spend a great deal of effort on the scholarly activity component of your curriculum. A best practice is to be sure that you have a well-developed mentoring program to support scholarly activity. So now we've come to the end of this snippet. Thank you for your attention, and please look forward to more snippets from Partners in Medical Education. Thank you.